There you are.
Well, good morning, everybody. I'd like to welcome all of you to the 8th Annual Research Symposium of the Center for Chronic Disease Research and Policy, based in the Department of Medicine at the University of Chicago. I'm Albert Huang. I'm the director of the center, and I'm a clinical investigator here at the University of Chicago. The Chronic Disease Center was formed 8 years ago, and our vision is to create a world where healthcare and policy seamlessly interact to improve the health of individuals at risk for or living with chronic diseases. And our mission is to develop and study innovations in the care and prevention of chronic diseases. Because of the pandemic, we've had to transform our typical in-person annual symposium into a series of 4 separate webinars. And despite the change in venue, I think you're going to if you haven't followed, has been about transcending boundaries, immigrant and refugee health in 2020. And it's both a timeless topic, but one that seems more important than ever. We're living in a time where people continue to seek safety and opportunity in a new country, despite the immediate and long-term physical and psychological risks. And they take on these risks despite the political and policy landscape. So we are extremely lucky to have today's speaker, our own Aresha Martinez-Cardoso. Dr. Martinez-Cardoso is an interdisciplinary public health researcher. Her research integrates theoretical perspectives from the social sciences with epidemiologic methods in public health to examine how social inequity in the United States shapes population health, with a particular focus on the health of racial and ethnic groups and immigrants. She works to interrogate how race and social inequities have been deeply embedded into our nation's culture and institutions, and traces the biosocial mechanisms by which these inequities get under the skin. Dr. Martinez-Cardoso holds a PhD in human behavior and health education from University of Michigan and a master's in community health sciences from UCLA. She's on the executive committee of the American Academy of Pediatrics Council medical interpreter, but she speaks French as well. So during the talk, please mute yourself. And if you have any questions, please type them in the chat box and I'll moderate questions towards the end of the talk. So just a reminder to everybody, we have a little thing next week called an election. So if you haven't already done so, please vote or make a plan to vote. And we're proud to support USHI Votes, which is a nonpartisan group trying to get out the vote on the university campus. And if you're not from University of Chicago, look to Turbo Vote. So without further ado, Dr. Martinez-Cardoso.
Hi, thank you all for being here and joining for today's talk. Thank you for that warm welcome. I think you were cutting in and out a little bit, but I think you said something like, I'm on a board in pediatrics. I'm definitely not, and that I speak French, and I definitely don't. So I think that might have been from a different speaker. I wish I spoke French. But thank you all. Thank you again for that warm welcome. I want to thank Dr. Wang and the center for the invitation to speak today and really organizing this fantastic virtual annual symposium, despite all the obstacles, I'm sure, of having to transition online. So there have been a number of fantastic focused talks in this symposium that tackled different facets of immigrant and refugee health. And then I thought today, to close the symposium, I wanted to offer some remarks, insights, and research that gives more of an eagle-eye view of immigrant health in the US and some of the challenges and perhaps pathways ahead to improving immigrant health. To be transparent and honest, most of my own work deals with the health of Latinx immigrants, and much of my discussion today will be most relevant for Latinos, but I think that many of the lessons that we learned can be translated to immigrants of other racial and ethnic backgrounds. So I'll start by, hold on, let's see. Okay, I'll start by giving an overview of chronic disease trends in immigrant groups and the leading approaches for understanding immigrant health. Then I'll turn to a broader discussion of the social determinants of immigrant health by using COVID-19 as a case study and drawing on some of my own work in birth outcomes and diabetes. And then finally, we'll reflect on the trends in chronic disease among immigrants and the leading research on social determinants to discuss future research, practice, and policy directions that we as a field can take to make inroads and progress on immigrant health. So let's start by discussing what we know about immigrant health overall, but especially related to chronic diseases. So first, from an analysis of NHANES data, which parsed out respondents by both nativity and citizenship status, we know that immigrants have similar levels of cholesterol, high cholesterol as the US born, lower levels of hypertension, and higher levels of diabetes. However, across all these conditions, immigrants, and especially those who were non-citizens, were less likely to have treatment if they did have the health condition. And then relatedly, we also know that, that immigrants are less likely to have coronary heart disease and stroke according to NHIS data. Now, if we look at another health outcome, looking at cancer mortality, here I'll show you in this figure, the authors display cancer mortality rates across 8 racial ethnic groups from 2005 to 2014. There are 2 lines within each racial and ethnic group, one for the US born and another for the foreign born. And consistently, we see that across racial ethnic groups, the foreign born, which is the dotted line consistently at the bottom, that the foreign born have lower cancer mortality rates when compared to the US born. So to put it together, if we look at another indicator, life expectancy and mortality, here I'll show you a table that compares the age-adjusted death rates for US and foreign-born men and women. And we see that for all racial and ethnic groups, this is first showing the rate ratios for men and then the rate ratios for women, that immigrant men and women have a mortality advantage over the US born men and women. And we see the trends are starkest for men, and then we see similar trends for women, but of course there's differences. We don't see the same mortality advantage among non-Hispanic white immigrants and Asian Pacific Islander immigrants. And then relatedly, infant mortality, another useful indicator of population health, is also lower among foreign-born women on the aggregate compared to the US born. So what we see from all of these trends and all this data when we put it together is that while the health of immigrants is pretty good overall, when we start to parse out the data, we find that exposure to the US, in fact, is detrimental to the health of many immigrant groups. So how do we know this? So we do research that either follows groups of immigrants over time in the US to see how their health changes, or we use cross-sectional data to break up immigrants into groups based on either the duration of time that they spent in the US or the age that they migrated, and we compare health across those groups. So this figure from a paper by Commodore Mensah and colleagues show that immigrants who have lived in the US for 10 or more years have significantly higher prevalence of obesity, hypertension, and diabetes, which they also confirmed in multivariate models with confounders. For those of you who are remembering back to your Epidemiology 101 class, the phenomenon that I'm speaking of is often referred to as the immigrant health paradox, where we find that on net, immigrants have pretty good health when they first arrive, despite often significant socioeconomic, environmental, and healthcare access barriers. But then that health advantage declines over time and generations in the US. So there's a number of explanations and mechanisms that researchers have proposed to explain the immigrant health advantage and subsequent decline in immigrant health. In some of my own work, I focus on the first 2 mechanisms that I show here related to health selection and return migration. But today, I'd like to focus on one of the arguments, which is related to health behaviors, risk factors, and acculturation among immigrants. So the health behavior and acculturation mechanism or argument suggests that the decline in immigrant health in the US is due to the fact that after migration and more time in the US, immigrants lose some of the health-affirming behaviors that they had upon migration, or cultural values and practices that once assured their health. So there's a lot of critiques of this approach and these explanations, both on the theoretical and empirical side. First, the evidence that many of these behaviors change significantly to drive immigrant health is quite mixed. Although it is very difficult to measure, especially measures of diet and physical activity, the evidence is really mixed whether or not things like smoking, physical activity, diet, and some kind of practices like social networks and social behaviors and support, religiosity, family values, whether that changes significantly among immigrants. The big caveat, though, is smoking. We definitely know that smoking increases among immigrants the more time that they're in the US. On the other side of the equation, and the flip, is that many researchers argue that immigrants really don't have these health behaviors and affirming practices they once had when they come here into the US, especially recent cohorts of immigrants, because globalization and changing economic and social circumstances in setting countries is eroding some of the health and behaviors and practices of immigrants that once protected their health when they migrated to the US. But then another argument is that even if health behaviors are changing and getting worse among immigrants, it's often framed in a way that makes it appear that this health behavior change is happening in a vacuum, right? That immigrants just come here, that they're losing these behaviors by their own kind of individual volition and will, and we need to intervene on encouraging them to adopt these behaviors again. And many population and immigrant health researchers have begun to really ask, but what about the social determinants of health, and how do upstream factors and mechanisms create the conditions by which immigrants' health behaviors and subsequent health changes? And can we think about intervening on those mechanisms rather than relying on traditional individual behavior change approaches? So social determinants of health has become a hot topic in health and medicine, but as a refresher, many of the most classic public health and medicine behavior theories often emphasize the individual when we think about health and health behavior, right? So we think about what are people's individual behaviors, how is their education or demographic circumstances shaping their own health and their health behavior. And then we also, to some extent, acknowledge their individual networks, like their family or their friends, and how that shapes their health, and some of the organizational aspects of their lives, like their access to healthcare systems and institutions and insurance that is also consequential for their health. But a social determinants of health framework takes a step back and instead it conceptualizes and rethinks how individual health is certainly shaped by our individual actions and behaviors, but that increasingly more upstream policies and systems shape the conditions that we live, work, and play, and subsequently our health. For immigrants and all of us, it is the constellation of all of these systems that work interactively to shape our health across the life course. So if we want to understand why the health of immigrants gets worse, it would be more useful to explore the social determinants that create risk and vulnerability for immigrant groups at a population level. So now I want to turn to a few research examples that show us how a social determinants of health framework can help illuminate some of the pressing health challenges faced by immigrants today, starting with COVID. So as many of you are aware, the COVID pandemic inequities in COVID cases and fatalities revealed, yet again, many of the fissures in our society and the pressing health challenges faced by immigrants today, especially the ways in which social inequalities engender health inequities across our population. So I was struck a couple of months ago about a paper that came out that showed that for older Latino adults, COVID-19 eroded the mortality advantage that Latinos adults experience relative to white and Blacks. So previously we talked a lot about how right now most immigrants and Latino immigrants experience a mortality advantage. So the authors showed that during the pandemic, Latinos experienced a higher burden of COVID-19 deaths compared to whites, and sometimes in certain age groups exceeded the rate, they matched the rates of non-Hispanic Blacks. And further, they showed in their paper that from 1999 to 2018, older Latinos had lower mortality rates than that of whites, but 2020 was the first year that the mortality advantage for Latinos relative to whites was eliminated altogether or greatly diminished. So while this paper and this data doesn't parse out COVID rates by immigration status, we know that much of the Latino mortality advantage is driven by immigrants, suggesting that Latino immigrants have been among the hardest hit by the pandemic. Qualitatively and anecdotally, we know that many immigrant communities have been especially hard hit by COVID, as well as the economic and social implications of the pandemic. But right now, data on COVID and immigrants is virtually non-existent. So in many states and regions, COVID cases and deaths often track with immigrant communities. So here I'm showing the map of Illinois, overlaying numbers of COVID cases with percentage foreign-born, where some county hotspots of COVID track with the concentration of immigrants. It's imperfect, it doesn't match perfectly, and we still need a lot more data, but anecdotally, this is what we think is happening. Moreover, the pandemic revealed many of the social determinants of immigrants' health that shape the risk not only for contracting COVID, but being hardest hit by the reverberating effects of the pandemic. So for example, immigrants face a labor paradox where not only are they more likely to be employed in essential jobs where they risk exposure to COVID, at the same time, economic data shows that immigrants were hardest hit by unemployment and job loss during the pandemic. As a result, both Black and Latino households reported the highest rates of economic precarity, as well as Asian households on some metrics, although to date, estimates for immigrants within these racial ethnic groups are yet unavailable, but we think that they're driven, particularly among some immigrant groups. COVID has also showed how our healthcare and social safety net systems are oftentimes designed to leave immigrants left out or fearful of utilizing these essential supports. So across the board, COVID relief and support has been limited for many poor families and individuals, but millions of immigrant families were excluded from stimulus payments because they were undocumented or the person that they filed taxes with was undocumented. In addition, there are many limitations in place on immigrants' utilization of food stamps, temporary assistance for needy families, and other safety net resources based on the way that federal and state laws regulate access to these resources based on immigration and citizenship status. And these policies and programs have not eased during the pandemic. Relatedly, immigrants, and especially the undocumented, have the highest rates of uninsurance, and many lack a medical home. So when they did get sick, many didn't know where to go or who to trust for care. Finally, earlier this year, the current administration passed laws I'm blanking on the term, passed laws related to immigrants' burden on the public healthcare system and public systems, and whether that burden would shape individuals' ability to access legal status and citizenship status. And because of these guidelines, individuals were fearful of utilizing healthcare and social services, and many folks distrusted government aid and resources. So there was qualitative stories coming out of New York and Baltimore that said that people were hesitant to utilize, for example, hotel rooms that were given to them so they could quarantine away from their families because they were worried they were actually going to be transported to immigration detention facilities. And there was one story that really struck me of a woman who said that her husband would just build a drywall wall that day so that way she could quarantine away from her family instead of her having to go to the hospital. And that just, is because of the distrust and the conditions that we've created for immigrants who are fearful of utilizing services, even when we put the systems in place to offer it to them. So it appeared that COVID is really truly the perfect storm and ignited many of the social vulnerabilities faced by immigrant communities. But now I'm going to turn to a different example of how our policies and social systems are designed to create health inequalities for immigrants, this time focusing on immigration policy and enforcement. So in this study that I worked on with colleagues a few years ago, we looked at a Postville, Iowa immigration raid, which was at the time the largest worksite raid in the US. It's now been surpassed by worksite raids that happened across the Midwest last summer. And so at the time, Postville, Iowa is a small meatpacking town in central Iowa. It's where a lot of folks are employed within what was a large agri-processor meatpacking plant where they packed like poultry and meat that were then shipped across the country to grocery stores. Immigration and Customs Enforcement wanted to make an example of this plant, and they engaged in a large worksite raid where they detained approximately 400 workers who were at that time 20% of the Postville population. There's many egregious factors and facets of this raid, including they brought in like military helicopters and had folks in SWAT gear and had buses that corralled people. And there were a number of federal whistleblowers that revealed many human and legal rights violations, both leading up to the raid and during the activities of the raid and the legal proceedings of the folks who were detained in the raids afterwards. And so we were interested in understanding what might have been the collateral damage and health effects of this raid, because folks were shocked by this raid, didn't know that it was happening, and they were fearful of follow-up raids that would impact the community within Postville, but across the state of Iowa at large. And to understand and study this, we turned to birth outcomes and we looked at birth records from the state of Iowa. And the reason that we look at birth outcomes is because it is a health outcome that is sensitive to environmental stressors, things like earthquakes and famines, but we thought perhaps a socio-political stressor might also map onto adverse birth outcomes. And also it is well measured. So regardless of immigration and documentation status, we have really good data on birth outcomes for all babies and all women across the population. And it's a discrete health outcome. So unlike some of the things that we've been talking about, like chronic disease, cardiovascular disease, cancer, a baby is born in 9 months. So we are able to more cleanly measure the effect of an exposure on birth outcomes. It's happening within a short period of time that we can compare. So in our analysis, we tested whether exposure to the raid was associated with adverse birth outcomes by using birth records data from the state of Iowa. And we compared adverse birth outcomes among non-Hispanic white and Hispanic or Latina women in the state. We weren't able to look at documentation status because that's unavailable on birth records, but we were able to parse out the data by immigration status. So we looked at both US and foreign-born women. And what we found is that after Postville, there was increased risk of low birth weight among babies born to foreign-born and US-born Latina women in the state. Specifically, Latina women were 24% more likely to experience a low birth weight baby in the period after the raid compared to the same 9 months in the year prior. And this effect we found this effect for both immigrant women who perhaps were more sensitive to something like an immigration raid, but also US-born women because US-born women are embedded within the same communities as immigrant women. So in addition to our study, a growing body of research suggests that increasing immigration enforcement and restrictive immigration climates are eroding the birth outcome advantage of immigrants as well as their co-ethnics who are embedded within immigrant communities. This evidence is very early and more studies need to be done. But in the similar ways in which COVID is eroding some of mortality advantage, there's some evidence that some of the structures and policies that we have in place are already also eroding other health advantages among immigrants. So what does Postville, Iowa and COVID today reveal about immigrant health in the US, and why should we pay attention? Well, my co-authors and I argued that Postville was an extreme case of the everyday, and the same is true for COVID. While we studied a particular noxious immigration raid and while COVID is particularly extreme and dramatic, there are smaller Postvilles happening across the country, and COVID is an extreme example of how the social conditions that we've created led to COVID inequities. But when Postville was over and when eventually COVID is over, these conditions will still exist to shape the health and life and livelihood of immigrant communities. So this is made apparent in a different project that my research team and I worked on that explored diabetes among immigrants. So in a recent paper, we conducted a review of the social determinants of diabetes management among immigrants. In our paper, we explored how immigrants were doing relative to the US born with respect to diabetes rates, but also the management of diabetes, including areas like glucose monitoring, eye and foot exams, exercise, medication adherence, and routine care. So from the literature, we found that diabetes prevalence was pretty mixed depending on the immigrant subgroups. So some immigrant groups are doing better than others with respect to whether or not they get diabetes. But on net, among immigrants, once somebody is diagnosed with diabetes, they were less likely to have optimal management and control relative to the US born, and we wanted to know why. So we took a social determinants of health approach and reviewed the empirical literature that showed connections between social determinants and diabetes management. We looked at this approach and we adopted this approach because the diabetes literature on immigrants was full of arguments that limited education or health literacy might explain many of the diabetes disparities among immigrants. But we knew that the story was more complicated, and we wanted to consider these more upstream factors that were consequential for diabetes control among immigrant groups. So in our review, similar to the trend we've been discussing with COVID and immigration enforcement, we found that a number of multi-level social determinants were consequential for individuals' diabetes management. So first, we found that healthcare systems really shaped individuals' ability to manage their diabetes effectively. There were persistent healthcare barriers that individuals identified that were due to either their immigration or legal status that shaped whether or not they could get consistent and quality healthcare. There was studies that showed that restrictive immigration clearances was linked to lower healthcare utilization. So if individuals lived in a place that had more anti-immigrant policies or policies on net, or there were healthcare systems that weren't immigrant friendly, that individuals were less willing to take care of their diabetes and consistently follow up with their diabetes care. And interestingly, you know, we've had immigrants in this country for a long time, and there are federal mandates on making sure that there are language resources for individuals in healthcare systems. But again, folks reported that oftentimes they encountered limited language and translation resources within healthcare systems, as well as negative healthcare encounters with clinicians who they felt discriminated against them because of their immigration status or their language or their cultural background. Moving away from healthcare, housing instability, precarity, and affordability was a major driver of diabetes management non-adherence. This makes sense. We were surprising how often we found this in the literature. So folks talked about how their house and their ability to live in one place and afford their rent and maintain a home was the pillar and the foundation with which their diabetes management either crumbled or was maintained. So if they weren't able to afford their home or they were experienced housing precarity, subsequently kind of all of their diabetes management behaviors, fell to the wind. And this makes entire sense, right? But this is something that we're not often thinking about when we think about folks' diabetes management and how can we help and support them. Also, things like neighborhood safety, people's levels of neighborhood safety were associated with things like engaging in prescription refills and physical activity. Of course, a lot of folks have talked about these kind of neighborhood environments and social resources within individuals' residential contexts that are consequential for diabetes management. And we found the same within the literature, that folks did a lot of studies, and there's findings that access to quality grocery stores, parks, and healthcare facilities is consequential for whether or not somebody managed their diabetes well. In addition, transportation and food insecurity was a big emerging problem, that when individuals didn't have access to these resources, that they often weren't able to manage their diabetes as well. And especially this phenomena of the cost and how expensive it is to be poor, which I think is what we've started to learn and realize in this country, that when people report, there was this one interesting study that looked at the USDA kind of healthy food guidelines and how much it costs to purchase healthy foods, that many individual immigrants within what they said were immigrant-friendly communities, the cost of affording food in these communities was more expensive because there was a charge up from many convenience stores as well as grocery stores in these areas that was more convenient for folks who had transportation barriers, but then the trade-off was the cost. And so then what ended up happening was folks traded off the quality of their the food that they purchased to balance the cost and transportation issues that they encountered. And then finally, I think folks have talked a lot about how we need to rethink diabetes management in light of individuals' cultural values or diet and family practices that are really important and central to their lives. And many immigrants in the studies that we looked at talked about how they faced many obstacles managing their food and diet within their family and cultural practices. And then oftentimes this is just something that doctors wouldn't talk to them about, that it was just an assumption that they were going to eat, kind of the quinoa and the grains and the turkey bowls, and that just didn't jive with their lived realities, and that they wanted to have that there was no guidelines we found for helping clinicians and practitioners to modify diabetes management and treatment with some of these practices in mind. And then and you know, this is what we found was kind of a big barrier to effectively working with immigrant communities for clinicians at the front line. So putting this all together, where do we go from here, and what lessons can we learn about immigrant health that we can use to promote population health overall and among immigrants themselves? So there's several research inroads that we need to continue to make in order to improve our science and understanding of immigrant health. The first is better data collection as it relates to immigration status and citizenship. Certainly some of the studies that I showed around COVID reveal that we don't have routine metrics on immigration status to be able to track how immigrant health is doing within the US. And then in a recent study that looked at a survey of CDC health monitoring systems, they found that only 30% of these systems collect data on nativity and only 11% collect data on citizenship. So we're really missing a big piece of the picture when it comes to immigrant health because we simply don't have the data. Next, well, especially in the current political moment, our work as health researchers is to locate and identify problems, and we focused a lot of, around kind of the current socio-political environment and how it shapes immigrant health. It won't always be like this, right? And it hasn't always been quite this fraught for immigrants. And so to that end, I think we need to look for and study policies and practices that assure the health of immigrants at a systematic level. And this is, you know, while the federal policies are not particularly immigrant friendly these days, states and localities and counties have stepped up and implemented many of their own measures to support immigrant communities. And perhaps we need to start looking at those counties and studying the effects of those policies. For counties that are going to experience increases in their own immigrant population in the years to come, as well as when and if the tide changes at the federal level and we start to rethink our approach and our policies related to immigrants. And then finally, I think while there's a lot of excitement around the work of social determinants of health and the language of social determinants of health, I think a lot more research needs to be done to draw the links between many of these factors that we know are happening at the upstream level and are shaping the health of people, the individual people down the road. While theoretically a lot of this makes sense, we still don't have the empirical literature to demonstrate the links, as well as to illuminate the mechanisms by which some of these social determinants shape health outcomes down the line. And this is important for thinking about what sorts of policies and interventions do we move on and do we invest in first, and thinking about where are we going to get the most bang for our buck. If we can't address the whole system, what pieces of the system do we need to focus on? Relatedly, I think we need to rethink how we talk about interventions for immigrants as well as for population health more broadly when it comes to chronic disease and health overall. A couple of years ago, you know, I was at an American Heart Association conference, and the keynote speaker hammered down that we need to meaningfully invest in lifestyle and risk factor interventions to improve things like nutrition, physical activity, and the whole cast of characters that lead to chronic disease, instead of relying so much on medical and tertiary care. I think we need to go one step further from this and think beyond the bread and butter public health and medical interventions that so many of us have been trained in and become accustomed to more fundamental interventions. So population health scientists often call these upstream interventions because they intervene on the social, political, and economic factors that shape the social determinants of health. And certainly some of these policy and programmatic interventions can be designed and implemented within health systems in mind. But as health researchers and practitioners, we also need to let go of the reins to some extent and champion policies and programs outside of the immediate purview of health. So what does this mean then for those who are more on the front lines, right, working with immigrant patients day to day or interfacing with health outcomes within a more clinical space? I'm sorry, let me go back. Quickly, when we think of rethink interventions for immigrants, this paper by Steve Wallace and colleagues at UCLA shows a framework and domains that specifically shape the social determinants for immigrants and provide key policy indicators to gauge how health affirming or health constraining a policy domain might be for immigrants, and points to some ways that we might think about social determinants of health interventions for immigrants. Okay. but to go back, so what does this mean though for clinicians, right? Those of you who are on the front lines and working with immigrants and maybe can't, right, work on a social determinant of health intervention or are constrained within the healthcare system within which we're embedded. So this paper shows what is the role of clinicians in thinking about social determinants of health, and if you are on board with the social determinants of health framework. And they lay out kind of key principles that clinicians should keep in mind when they think about working with the health of vulnerable populations, including immigrants, and some of the approaches that they can take both in their clinical practice as well as their advocacy overall and research to adopt the social determinants of health framework within their own practice. Okay, so with that, I will go ahead and stop. Thank you again from the center for the invitation, and we have plenty of time for discussion and questions, and I welcome all of your feedback and thoughts. Okay, let me stop.
Thank you so much.
Okay, yeah, thanks.
All right, so we do have a question, and please everyone, don't be shy. So from Milky Vu, her question is, do you think there are challenges regarding asking people to self-report citizenship or immigration status given the current political climate around migrants? And then how can we overcome them to collect accurate data on immigration status?
Yeah, this is a good question.
An issue in the census.
Yeah, this is a really good question. I think it depends on the approach, and there's two answers I will have, because we always want more information on citizenship status, and really the question there is, we know the undocumented are the most vulnerable, right? So we need good data on the undocumented. So there's kind of two approaches. A lot of demographers have developed kind of these imputation approaches, and they try to estimate and use all sorts of models to guesstimate who are the undocumented or what is people's citizenship status based on current available data. So Jeffrey Passell over at the Census or the Pew Hispanic Center has been doing a lot of this work, and it's pretty good, right? Like it gets us at pretty good estimates of who is undocumented when we don't have that information directly. There are other studies that work really well within immigrant communities and develop the rapport to be able to ask questions around citizenship. So the one that comes to mind is the study of Latinos. They do collect information on citizenship and immigration status because they have been deeply embedded within many of the communities within which they are collecting data and have developed trust, right? In the study that I worked on many years ago, we also did sort of like roundabout ways of asking about documentation status. So we would ask people, what is your main form of ID that you use? And so then people were able to report, you know, I have a driver's license, I have a matrícula consular or a passport from my home country, and we were able to use sort of what identification people use as a proxy, right, for documentation status. It's always imperfect. It's never going to be great because of the fear and distress that people have around reporting themselves to the system, but there are ways around it, and there are ways that we can be creative, certainly.
Great. There's a new question from Loretta Shui. Something from your recent paper really stuck out at me as Immigrant Health diabetes researcher. You found that social determinants of health were routinely highlighted in studies with Latinx immigrants, while culture and family dominated in studies of Asian groups. What might this say about the stereotypes we as researchers bring to the process, and how do you think this has affected research progress? This is actually kind of an interesting question around you know, findings across different immigrant, or the way we do research across different immigrant groups. What do you think about that?
Yeah, that was an interesting finding for us too in the paper, and I think it goes back to the myths that we tell ourselves about immigrant groups. So, you know, there are a lot of, and I think I'm excited we're having this conversation because there are a lot of Latino immigrants, but the growth of immigrant groups in the US is driven by Asian immigrants, and there's so much heterogeneity, right? I've just been saying like immigrants, right? But there's so much heterogeneity within groups. And I think the story that we tell ourselves is that Latinos are the most socioeconomically vulnerable and that Asian immigrants are doing really well, But when we parse out the data, there's so much variation, right? So some Latino groups, for example, like Cubans, do really well because they have many socioeconomic advantages. And then in some Asian groups, when we parse out the data, like Filipinos, for example, they don't have as good outcomes as other Asian immigrant groups, right? But that's not really the nuance. We're not really thinking about that and exploring that. Also, like immigration health is like a niche topic within so much population health, but there are so many immigrants all over the place, and I just wish it wasn't so niche. But to more directly to your point, I think we have these like national narratives and stories that we tell ourselves about these immigrant groups. And I think that does a disservice, right, for especially for some of these Asian groups who we think that they're doing very well socioeconomically, but they are also experiencing many barriers economically, employment, housing, right, that we also need to address, especially within some subgroups, and just kind of learning the nuances of those groups is important. I think also kind of going back to the explanations for immigrant health, we also often have this very romanticized view of immigrants, right? That like people are, come with these like very health affirming practices and like love families and like have these cultural, like we just throw around this word cultural, like cultural behaviors. Well, everybody has culture, right? And so I think if we were realistic with about the social and economic circumstances facing folks and how that interfaces with their health, as opposed to being too romantic, right, about culture and saying everything is about culture, I think we would make more inroads on immigrant health by kind of dealing with some of those realities.
Got it.
Yeah.
Thank you. Can you talk a little bit about the history of the census and immigration and citizenship? What's the history there? Have we ever asked about citizenship before?
Yeah, that's a good question.
What's the reason not to? And
yeah, that's a good question. I don't know off the top of my head if we've asked about citizenship. The Pew Center has this really cool infographic called What the Census Calls Us that looks at how we've measured race and ethnicity over time. And I wonder if somehow citizenship has been baked into that infographic or is baked into those questions. I mean, for a long time, right, the census only collected data on people who were citizens, right? And then they ignored everybody else. And so I think now, like politically, right, the debate around asking citizenship questions were that people were not going to, although it's an important metric, coming from the government, it would make people feel incredibly unsafe. And also it could be weaponized, right? Like we could turn around and use that citizenship data to shape how federal funding got allocated, that only districts at high levels of citizens would get access to federal funding, right? And that would leave large communities that had large populations of immigrants or those who are undocumented kind of out of federal funding. And so I think there are risks to collecting citizenship from such high level government sources like the census. And so we kind of have to get around it. Yeah.
Right.
Yeah.
Okay.
So
Go
ahead.
A question for you about you talked about you gave that great example from Iowa of really it's a policy evaluation of sort of a punitive
yeah.
Pottsville. Right. And you mentioned that there are possibly ways of studying immigrant-friendly policies. Or can you give us some examples of what you mean by that? What are examples of sort of immigrant-friendly policies, and how does that fit in? How do they fit into the overall kind of picture for immigrants?
Yeah. One of the things I laugh about is like public health researchers are always looking for problems, and we find them wherever we go, and we don't try to look for the successes or what policies actually make sense. And I think my colleague, Lauren Salisbury, who's in my department, always talks about how like, we know what policies need to get implemented, we just don't have the political will to do them. And I think for immigrant health, oftentimes we don't know what the policies are that need to be implemented. But some examples that we do know that I don't work on, but colleagues do, that I've read papers are things like expanding access to social services for immigrants. So the states, for example, that expanded their state health insurance programs, so those who are undocumented, there's kind of health economists and health policy folks are looking at like, how does expanding health access, for example, in California to the undocumented, how did that shape and help population health overall? Because there are ripple effects, right? We found that when that was expanded, the children of immigrants and the children of undocumented immigrants had better healthcare utilization, even though before the policy, they already had access to healthcare because of the kids programs, but just by giving the adults health insurance, you kind of ushered the whole family along, right? Similarly, when we looked at the expansion of immigration protections for young undocumented folks through DACA, that was also found in the literature that when you expanded the protections for DACA folks, you saw a whole host of reverberating effects in terms of educational access and healthcare, and thinking about how there was ripple effects for those policies as well. So those are just two examples. I mean, people have really been thinking about, you know, the sanctuary city policies across states and cities. And, you know, to be frank, sanctuary cities policies are great because I think they help people feel like they live in a more safe area, although sometimes it doesn't mean that they are really protected by ICE and immigration enforcement. So there's ways that we can think about in what ways do sanctuary cities, or just those, the messages that we send for immigrants in a certain place, can be psychosocially affirming to their health, even if the structures aren't there, or in addition to the helpful structures for people's health, right? So there's the two kind of different mechanistic stories that we can think about. And again, you know, one of the calls that I make is, again, the stories that we tell ourselves about immigration and immigrants is that we often think that immigrants are, you know, reside in the Southwest and Texas and California, you know, here in Chicago, but, you know, the states that are experiencing the largest increases of immigrants are in the South, are in places like, you know, the Dakotas, right? Maybe not absolute numbers, but percentages, and then eventually absolute numbers are going to increase. And so these places are more and more going to be dealing with immigrant communities of diverse backgrounds, and they're going to look to kind of the examples of California and Illinois for what are the policies and practices they should implement in the years to come. And we need an evidence base to provide, you know, if you're going to implement one thing, this is what it should be. And I don't know if we have that just yet across the board for immigrant health.
Got it. Well, let me ask you also a kind of, clearly the country is quite divided over immigration. What would you say to someone who's like, why should I care? You know, why, you know, this may be obvious to those of us who are on this call, but why do we want a healthier immigrant population? Why should we care about immigrant health for the long, you know, for the country as a whole?
I
mean, that may be.
I'll give you two answers. The first is, you know, we have to be careful when we answer this question, right? Because the immediate answer is immigrants in the US today are the drivers of population growth, right? So more immigrants are having babies and are going to be fueling the economy and our labor market and our labor supply in the years to come, right? So as the non-immigrant population gets older, the immigration population is going to become more and more the working age. They're going to be funding our taxes, our Social Security. Already, immigrant groups fund much of that and contribute to much of these systems, more likely to be employed, all of those things, right? And so in order for the US to thrive, like, immigrants have to thrive, and we have to protect, right? And the damage that we make to immigrants' health overall, now as people are aging, is we're going to have to pay for that at some point, right? But I want to be cautious about this kind of dollars and cents argument, although it's like the argument that, you know, often brings people to the table because, you know, immigrants aren't just the labor that they provide for us. So I think that, you know, we as a nation, I think, in the same way that we are kind of having the conversation around race, right, about contending with our past, our racial past and racial inequality, I think we also need to contend with our like our history as of globalization, and many of the sending countries for these immigrants, you know, wreaked havoc in many of these countries that created the conditions by which they um, either due to violence or economics have been pushed or pulled out of their country, right? And so that is our responsibility as kind of this global player. But I don't know if that's as palatable to people as the kind of the labor and the older and like the Social Security argument, but that is the reality, right? Many of these immigrants are coming from places that we messed up, right, in the 80s or the 90s or through our economic and globalist policies, and we are reaping those rewards now through our immigration channels. So that is the reality, and we can ignore it, but ignoring it has led us to the point where we have millions of undocumented folks who are deeply embedded in our communities and our workplaces and our healthcare systems. So I wonder if we can deal with the reality and not ignore it as much, right?
Wow. Yeah, that's a very thoughtful answer. There's both kind of an
It's hard.
economic,
Yeah.
kind of a hard, um, cold
Dollars and
economic,
cents. Yeah,
dollars and cents
yeah.
economic answer, but there's also a kind of a just a
An ethical
humanity,
answer. Yeah, yeah,
ethical and
yeah, yeah,
human, something based in just human
yeah.
experience
Right,
that. And I mean, the other thing is, it actually does touch on the larger themes of that the world is smaller than it was before, and that there is just globalization, um,
right,
some you know, by economic design, but
right.
something,
Yeah,
the world is just shrinking because, you know, we
yeah,
can more
definitely.
easily travel
Yeah.
across the world. Um,
Yeah, related to that too is, you know, there's a lot of concern about like rural America, right? And like farm working and like these dying rural places and the opioid crisis, right? Like if we look at the data, it are immigrant communities and laborers who are revitalizing many of these rural places, right? And they're the ones going there and sending their kids to school, right? Those places that a lot of the younger folks have left, right? So if we think about how how can we revitalize many of these places and build those communities back up, you know, not to say that immigrants are the answer, but they are kind of doing that work for us, right? And so that's also another way to think about it as well, which I think people forget so much because we think, you know, all immigrants are in Chicago or LA or whatever, and they're not.
yeah, not
um,
at all. No,
yeah,
clearly they're in Iowa.
yeah,
Um,
they're definitely in Iowa.
right.
Yeah, yeah,
Right. Um, well, this has been an amazing discussion.
yeah.
If you think about, you know, I mean, I want to go back to a question that I think Loretta asked about sort of different ethnic groups. You know, two talks ago, Alka Kanaya talked about how the immigrant experience for South Asians. These were largely, I think, they're a different socioeconomic group, but it was largely positive actually. That they were
Mm-hmm.
adapting better. They were that actually the Westernization was actually a positive for their cardiovascular risk. And
Yeah,
then in this case, you know, in the Latinx population, we're talking about sort of actually in some ways a worsening of health with the immigration experience.
yeah,
Is it just mixed? Is it both positive and negative? Is it just simply complicated, or can we say
yeah.
something definitive about the immigration experience?
Yeah, it is complicated and it's always hard to talk about immigrants writ large, right? But I think the kind of they come healthy and then they get worse, that is really a story mostly for Latinx immigrants, certain Latinx subgroups, mostly kind of Central Americans and Mexicans, as well as for many African and Black Caribbean immigrants, right? And then that trend is less strong for many South Asian groups, but it just really depends. And part of it, I think, is, you know, as we were doing that paper, the diabetes paper, And as I was preparing for this slide, is like we just don't have good data on some of these subgroups to be able to parse out effects over time. But I think with the Asian groups, subgroups of immigrants, for any of the emerging kind of researchers out there, I think the field is ripe to be able to kind of pick that data and look at it more comprehensively and see where are the variations, because we're seeing this increase of Asian subgroups over the last 10 years. So, you know, to be determined and to see once we start to parse out the data a little bit more.
Wow.
Yeah, the one I can speak to most is it's happening for Mexican, Central American, and certain some Black immigrant groups. Yeah.
So there's a lot more to do in people just crossing boundaries from different countries with different backgrounds. And it's a beautiful, it's also a great illustration of the role of how policy and medicine and public health interact.
Yeah.
So Aresha, I just want to thank you again for closing out our symposium, and what a great talk.
Thank you. Thank you so much for the opportunity. And everyone, reach out if you have any questions or want to connect. It's been a pleasure.
Great. Thank you, everybody.
Thank you all.
Have a great day, and thank you, Aresha, again.
Thanks. Bye.
Bye-bye.